very good afternoon today. Today I am going to discuss about the topic of keratoconus and its treatment modalities. Okay. So when we are talking about keratoconus, the first treatment comes in our mind about the CXL. Okay, the collagen crosslinking, right? Corneal collagen crosslinking. So today we are going to just go through what are the different types of CXL we can do. Okay, so in your routine OPD, when a patient comes to your clinic with a complaint of blurring of vision with retinoscopy, you got a scissoring reflex, and you send the patient to do a topographic evaluation or pentacam or corneal topography, where you will find out all the relevant parameters as keratoconus, including the Kmax, the Bellin ratio display, the anterior and posterior float elevation. So now you reach the diagnosis of keratoconus and plan to treat. Now there are two types of treatment for keratoconus, right? So one treatment, that is a CXL, is to stop the progression, and another type of treatment we can do, that is the advanced treatment options, that is the TGPRK, topography guided photorefractive keratectomy along with CXL surgery. So what patient you should go for the TGPRK CXL, or what patient you should go for the CXL, that we need to understand. So the patient with the corneal thickness of 450 microns or above and whose spectacle corrected BCVA is 618 or above, we can go through the TGPRK plus CXL. Okay, so we will do the CXL and then we correct the power also with the topography guided photorefractive keratectomy procedure. So in that case, in that all cases, we have found that post-operative vision is improving. Almost it comes to the 6.6 and parts, and binocularly patient can easily read 6.6, almost 90% of the cases. Okay. But if the patient has very advanced keratoconus or even the spectacle corrected BCVA is 618, less than 618, then we should not go for the TGPRK with CXL. So then we first only focus on this collagen cross-linking only. Okay, CXL. Now, what are the types of CXL? So if a patient comes to you and you of keratoconus patient and you show the topography, one patient the corneal thickness is 280 micron, that is a very advanced keratoconus. You get one keratoconus patient thickness as 350 microns, and another patient you get a keratoconus patient thickness about 430 microns. So which type of CXL you do for each patient? So the patient with 420 microns, you can go with a normal CXL. Okay, that corneal collagen crosslinking. The patient with the almost 350 microns, then you should go with the hypotonic CXL. Okay, so the hypotonic CXL means the riboflavin vitamin B12 solution, which has to be given to the corneal stroma and then we put the UV light exposure, right? So that in case of the hypotonic CXL, that riboflavin concentration will be, it is a low salt concentration. Why it is so? Due to that low salt concentration, the corneal stroma is getting swelled up, so that the corneal thickness is to some extent it can increase. Otherwise, when the patient will undergone with the UV light exposure, that UV light may pass through the corneal endothelium and reach to the corneal endothelium and pass through it and make a cataract for the lenses. Okay, because the cornea is very thin. So in case of the moderately thin cornea, we should go for the hypotonic CXL rather than normal CXL process. Okay. There is one more process that is called the AP off or AP on CXL. So AP off means the surgeon will first remove this total epithelium, then they put the riboflavin solution and the UV light exposure. And AP on CXL means the epithelium will remain intact by a method of isopronitation that riboflavin is given to the corneal stroma, and then the UV light has been exposed. So if you compare about the efficacy, so definitely when the epithelium is removed, the riboflavin absorption is much better than when the epithelium is on, epithelium is intact. So along with the efficacy, the epithelium off procedure is a gold standard, but nowadays many surgeons are doing the epi on or epi intact. In that case, the comfort will be better and the vision recovery will be more. But if you compare about the gold standard efficacy, definitely it is a AP of CXL. Okay. And when the patient is very advanced keratoconus, when you can easily just look at the patient, you can see that there is a Munson sign, and in the slit lamp you can see the acute hydrops, Vox try, all these things in the slit lamp. So, and the thickness is very low, like 280 microns or 270 like this. So there you should not go with the CXL at all. You should directly go to the transplantation procedure. You should first start with the DALK, the deep anterior lamellar keratoplasty. If it's failed, then you should go for the PKP, penetrating keratoplasty, total penetrating keratoplasty. Okay. So this is all about a very brief discussion about the keratoconus, advanced keratoconus and its treatment modalities. Thank you.